right, so let's try this talk again. I know there were some issues with the audio and the video not syncing up in my last video, so my apologies for that. Let's try it again from the top. So starting off with this first case, we've got a case of Wharton tumor, and this is a really nice gross example of this tumor where you see a cystic component and then these more solid areas with papillary excrescences. If you'll recall that the Wharton tumor is called cystadenoma lymphomatosum papilliferum, right, this is exactly what we're seeing. We're seeing the cysts and the papillary areas. And this is a good time to talk about kind of a approach to grossing of salivary tumors. You want to definitely sample these thoroughly. They have a range of microscopic appearances rather, that can be quite challenging if you don't get good sampling. So really sample these thoroughly. You want to look carefully at the capsule, if it's encapsulated or if it's infiltrative. That's very important. There's certain tumors where that infiltrative versus well-circumscribed pattern is very helpful diagnostically. So you definitely want to look for areas where potentially there's tumor protruding through the capsule, invading through the capsule, since those will be diagnostically very important. You want to look for potentially lymph nodes in the background salivary tissue as well, since there are often intraparotid lymph nodes in the parotid, for instance, which is one of our more common samples. So this is a nice example of Wharton's tumor, and often these cystic areas are filled with what's known as kind of this viscous fluid, often called used motor oil. And on FNA particularly, you can get some of these cystic components that come out very prominently. All right, so moving along to the microscopic of this case, this is the same tumor, a Wharton tumor, cystadenoma lymphomatosum papilliferum. You can see over here there's some benign salivary tissue, and then over here we have this very proliferative neoplasm. And just thinking about my approach to salivary tumors, one of the first things you want to do at the time of gross or microscopic is look at that border with the normal tissue. So is it well circumscribed? Is it infiltrative? Is there desmoplastic response? How well circumscribed is this thing? Because that's going to give you a lot of clues as to whether this is potentially benign or malignant. So here we have a very well circumscribed tumor. So already we're thinking, oh, this is probably benign. And even from a very low power, we can see that this tumor has a bunch of different colors. It's got some blue areas. The epithelium looks kind of pink, and then there's some cystic components as well. So this is kind of an Aunt Minnie diagnosis where if you saw this on the slide, you would say, oh, I know what this is. This is a Wharton tumor. So on closer inspection, we can kind of take a closer look and confirm what we already knew from low power, which is that this is a Wharton tumor. So we have these lymphoid areas with germinal centers arranged in these papillae, and the papillae are lined with oncocytic epithelium. And we have some cystic areas as well. So taking a closer look at this oncocytic epithelium, they have a characteristic, of course, as with all oncocytes anywhere in the body, you have abundant cytoplasm, some of which is granular. It's kind of hard to tell from this power. This is as high up as we can go, but the cytoplasm is very granular, and that's because they're full of mitochondria. So back in my day when dinosaurs roamed the earth, the boards might show you an EM photo of or photomicrograph of a bunch of mitochondria in a cell, and the answer was oncocytoma. And so oncocytes anywhere in the body are going to be filled with mitochondria. In Wharton's tumor, the oncocytes have a unique feature, which is this bilayer of nuclei, where you have some more basally located nuclei and some more, I guess, apically located nuclei. You can see it very nicely here. And then again, you can have varying components of the cystic proportion. So Wharton tumor, very common salivary gland tumor. The classic kind of boards scenario for this case would be a bilateral, quote unquote, doughy salivary masses in an older male who was maybe a smoker. I think that was kind of the historical demographics of this tumor, but in more modern times, it seems like the gender predilection is about actually 50-50. So I see a lot of these in women as well, and not always in smokers. And there's an interesting thought, which is that potentially that these Warthin tumors are arising from intraparotid lymph nodes. So you think about it, from an embryologic perspective, where is all this lymphoid tissue coming from? And as some evidence for that hypothesis or thought, there have been some case reports of tumors that have metastasized to Warthin tumors, and we've seen some cases of metastases to Warthin tumors as well, which would kind of argue for that hypothesis. Another interesting point to make is that in some Warthin tumor, you'll see more areas of oncocytic overgrowth. And then conversely, in some oncocytomas, you can see areas that look more Warthin-like. So there's been some speculation that oncocytomas and Warthin tumors are kind of two ends of the same spectrum. So interesting things to think about. All right, so moving on to the next case. So here we have a mucosal surface up here, and we have a proliferation down here in the submucosa. And kind of going back to the basics of, well, is this thing well circumscribed or is it infiltrative? Kind of hard to tell with this one, right? So you can kind of draw a line around it. It's not super infiltrative, but it's a little hard to tell kind of where the tumor ends and where maybe some of the surrounding tissue um, begins. So not the best circumscribed tumor, but not the most infiltrative either. So kind of a little bit tweener on the borders of this one. So now let's look at what cell types are composing this tumor. So the next step, once you've decided whether your tumor is infiltrative or not, or in this case, not really sure, decide what cell types are making up a salivary tumor. And in your normal salivary gland, of course, you have lots of different cell types. You have stroma, you have epithelial cells, you have ductal cells, you have your myoepithelial cells. And so it's helpful on higher power to take a look at what cell types are making up this particular tumor. So this particular tumor kind of has a lot of different things going on. So we have these areas that are kind of more pleomorphic and look alternatingly kind of squamoid. Some of these look like maybe they have some clear cell change. There's cystic areas as well with macrophages. And then there's cells that maybe look like they have a little mucin in them. See if we can find some better ones. Here we have some nice mucocytes. And then there's some cells that are kind of in-betweeners or intermediate cells. And so if you've got a tumor that's got some kind of more squamoid or epidermoid cells, some mucocytes, and some cells that maybe aren't one or the other, and has some cystic areas as well. So what am I describing? Mucoepidermoid carcinoma, right? The most common malignant salivary gland tumor. And the three main cell types, as I've described to you, are really these squamoid or epidermoid cells, the mucocytes, which sometimes you have to hunt for. They can be a little focal, but this one has some pretty nice ones. And then the intermediate cell, which is, kind of a cell, maybe these that are kind of not really exactly epidermoid or squamoid and not exactly mucocytes. And the prognosis for these depends on the stage, the grade, and the margins. And there's a number of different grading systems. And more or less, the important things to keep in mind with the grading systems are that the more cystic component you have, the better. The less cystic component you have, the worse. Things like perineural invasion, necroses, increased mites, and anaplasia, of course, as you would imagine, all typically lead to more intermediate or high grade. And the pattern of invasion is helpful as well. So a relatively well circumscribed one is more likely to be a low grade tumor, and you can kind of refer to your own institutional personal preferences for your favorite grading system for these mucoabs. And then from the perspective of genetics, right, these tend to have mammal 2 rearrangements. All right, moving on to the next one. Nice low power view of this very classic tumor. Looks like we've got some positive margins here. But, can we draw a nice circle around it? And I would argue that, it's got kind of a thin capsule, well, relatively well circumscribed. And again, we have some tumor on ink, so can't really perfectly assess it there. But looks like a well circumscribed, if a little bit lobular tumor. And so let's go on higher power and see what is making up this tumor. So from low power, we have this kind of bluish, maybe chondromyxoid stroma, as well as these epithelial elements as well. And so we can see this chondromyxoid stroma is very, very prominent. And we have these epithelial elements. And maybe if we look closely, maybe some little small dark myoepithelial cells as well. So we've got a tumor that's relatively well circumscribed, made up of chondromyxoid stroma and some epithelial and myoepithelial elements. And this is another kind of classic Aunt Minnie. This is a pleomorphic adenoma, which is, of course, our most common salivary tumor in whether you're in the parotid or submandibular gland or minor salivary gland. These are really going to be kind of your most common salivary neoplasm. And this case kind of shows off one of the elements that can be problematic with PAs. So even though they're a benign tumor, they can kind of shell out because they're lobular. Sometimes they can be transected at the time of surgery. And so even though they're benign, you can get local recurrence just because you can get little lobules of tumor that are left in that tumor bed, not infrequently. And so they can cause problems just through local recurrence. In terms of the genetics of these are associated with PLAG1 and HMGA2 mutations. There is an IHC for PLAG1. I don't tend to use it a lot in my practice, but it may be something that you'll come across in yours. And then from the perspective of diagnoses, when you have the whole thing like this and it's relatively classic, pleomorphic adenoma is a pretty easy diagnosis, but given the name, right, it's pleomorphic, you can get a range of microscopic appearances, and that could be problematic when you're dealing, particularly, for instance, if you're dealing with an FNA of a cellular PA where you're seeing, you know, lots and lots of the epithelial component and not as much of the kind of classic chondromyxoid stroma that you often see as troll hair. Looks really beautiful, magenta on a dip quick stain. And so it can be a little bit problematic preoperatively if you don't get a sample of kind of all of the various components. The other problem that you have with PAs is, you know, the clinical history would be, oh, this person comes in, and this is not what we have on this slide. This is just for discussion purposes. Oh, we have a person who comes in, they've had this salivary tumor for a really long time, it's been stable, and then all of a sudden it's had, you know, explosive growth, right? And so if that's the board's question, the answer is going to be carcinoma XPA, right? And that is pleomorphic adenoma with an epithelial malignancy that arises in it. So it is the minority of PAs, and the clinical history, you know, you may or may not get that classic clinical history of explosive growth. The malignant component is usually a poorly differentiated adenocarcinoma, but really can be any kind of salivary gland carcinoma. And the prognosis for carcinoma XPAs is very much dependent on whether it's non-invasive, minimally invasive, or invasive, right? So the more invasive the carcinoma component is, the worse the prognosis. Makes sense. All right, so let's move on to the next case. All right, so back to our basics. Is it well circumscribed or not? And I would argue that it is, in fact, very well circumscribed with a relatively thick capsule. And even from this low power, we can tell that it's a very, very blue tumor. And so let's take a closer look and see that this is a very, very basaloid neoplasm. And when we think about basaloid neoplasms in the salivary gland, we have kind of a broad differential. You can get things such as basal cell adenomas, basal cell adenocarcinomas. You can get pleomorphic adenomas that look basaloid, so cellular PA. Certain adenoid cystics can look very basaloid, and things like even metastases from, for instance, head, neck, HPV-related squamous cell carcinomas can be very, very basaloid. And so, you know, when we see these on cytology, these basaloid salivary neoplasms can be a real challenge. So on this case, it's again, you know, kind of going back to the circumscription, the pattern is pretty much all basaloid and it's well circumscribed. So this would fit with a basal cell adenoma. And basal cell adenomas, you know, it really is kind of a morphologic diagnosis. You can do some IHCs, you can get a CD117 positivity. These are going to be P40 and P40 and P63 positive, peripherally, have nuclear beta-catenin. Honestly, again, in my practice, I don't do a ton of IHCs on these. It's kind of, again, a morphologic diagnosis. All right, so basal cell adenoma. And that is in contrast to this next case where we can see, going back again to basics, is it well circumscribed? Is it not? And it's actually not particularly well circumscribed. So we can see that there's these fibrous bands and there's a relatively basaloid appearing tumor infiltrating out possibly into the fat here. So pretty infiltrative. There's a little bit of lymphoid component associated with it, and there's these islands. So pretty, infiltrative. And then as we look at this tumor, again, we're seeing a very, very basaloid morphology with peripheral palisading. And so this is an example of a basal cell adenocarcinoma. And this is an example of where, that border is really, really important. So the distinction between basal cell adenoma, basal cell adenocarcinoma, often rests really on that capsular infiltration and finding evidence of capsular infiltration. And this one, I would say, it's not as difficult to decide because really it's not very well encapsulated and we have lots of infiltration into the surrounding tissues. All right, so next slide. Again, we're looking from low power at whether this thing is infiltrative or well circumscribed. And kind of like the last case, we have these lobules of tumor, not really well circumscribed, not really kind of, these jagged finger-like projections, but really more lobules of infiltration into the surrounding tissue. So already worried that it's something that is malignant. And let's take a look at what is making up this malignancy. So what cell type is making up this tumor? And as we go on higher power, we can see that the tumor cells are actually relatively bland and that they have a bit of resemblance to normal acinar tissue. So if we move over here to the normal salivary acini, you can see these little kind of zymogen granules within these acinar cells. I will point out, though, that the normal architecture of these acini is really round and grape-like, right? So acini for cluster of grapes, these are really round little circles of benign salivary gland, just like you might see on FNA. But as we go over here, this tumor from a cytomorphology perspective, hey, these cells look very much like acinar cells, right? However, the architecture is pretty diffuse and infiltrative. So all of that goes together to make this a acinic cell carcinoma. So as we look around, we can see again, this is a relatively bland tumors. These tumors tend to be low grade, but they do have, this one does have some infiltrative architecture. And again, just kind of sheets of these tumor cells with acinic differentiation. So this tends to happen in younger patients in the late 30s and 40s, female over male predominance. And again, this is one of these tumors where if you got a cytology sample or a small biopsy, it could pose a little bit of a challenge because from a cytomorphology perspective, hey, these look like bland, could be just normal acinar epithelial cells, right? So if you have an FNA that is not particularly cellular of an acinic cell carcinoma, your differential might include, normal gland, because if you're not getting a lot of these cells and you're not able to kind of see the cytoarchitecture, it can be a challenge to distinguish this from just benign normal gland. That being said, here's a nice area where we can compare and contrast. This is a little bit more normal gland. Again, you've got that nice round little acini that you'll see. And on cytology, these will be really beautiful little three-dimensional clusters versus acinic cell carcinoma, which is more diffuse architecture, will be in sheets, will be more adhesive. So on cytology, those would be features that would lead you towards the diagnosis of acinic cell carcinoma versus just normal gland. And in general, these tumors have a good prognosis. They're indolent tumors, and they have kind of a protracted clinical course, but overall, low-grade tumor with a good prognosis. All right, so moving on to our next case, mammary analog secretory carcinoma. Actually, sorry, I just gave away the diagnosis, but it's up there so you guys can see it already. Again, let's look at the infiltration or borders of this tumor. So again, kind of a lobular tumor, not the most well circumscribed tumor. And as we go on higher power, let's see what cell types this is made up of. So we have some cystic areas, and we have a lot of bubbliness going on. So kind of bubbly cells, cystic areas, maybe some areas where you go over to almost kind of an apocrine or secretory look to a lot of these cells. And so if you think about this tumor, this was initially called mammary analog secretory carcinoma. Now it's called secretory carcinoma. And it looks like, if you were looking at breast, a secretory carcinoma of the breast. I mean, if you think about it, the breast is just a modified salivary gland, right? And this tumor can have a lot of cystic components. And if we back up, we can see that there's some cysts. Some of these can be predominantly cystic, so you really want to make sure you're sampling the wall of the cyst to make sure you get these tumor cells. And you can get these bubbly secretions. They can be eosinophilic, as we can see here, but bubbly, eosinophilic, almost to me has kind of an apocrine pattern to it. And you can get a microcystic pattern, you can get tubular patterns, you can get more solid areas as well. This one has a lot of these kind of more microcystic and bubbly areas. These secretions will be positive for PAS with and without diastase. They'll be positive for alcium blue. And if you do IHCs, these will stain kind of like a breast. They're positive for S100 protein, positive for mammoglobin, positive for GATA3, and these have a characteristic translocation. And that is, they have translocations involving ETV6, and it'll have an ETV6 and TRAC3 usually fusion product, and you can fish for these. So if you're on the fence as to whether it's a secretory carcinoma, fish can be your friend. All right, so what used to be called mammary analog secretory carcinoma, now it's just secretory carcinoma. All right, so this is another cute case. Sorry, I should say classic case. In this case, we can't really apply our criteria of is it well circumscribed or is it infiltrated, because the tumor is pretty much taking up the entire submucosa here. But we can see that it's basically filling up the submucosa. So it might be kind of more of an infiltrated versus well circumscribed tumor. The next step, of course, is to see what cell type is making up this tumor. And as we look, we can see that there's a couple of different cell types, maybe kind of an inner epithelial component, and then this more kind of clear or myoepithelial appearing component. Let's see if we can find a more classic area. So here we have kind of a nice dual layer of an epithelial and then myoepithelial cells. And some areas have a little bit more of that myoepithelial or kind of clear cell adhesive look. So I have just described, of course, epithelial myoepithelial carcinoma. So this is a rare tumor, biphasic, right? Again, epithelial and myoepithelial. Parotid is going to be the most common site for these, and typically these are low-grade tumors. And these tumors are ones where, I tend to think of IHC in the salivary gland as something where you can use it to help highlight the different cell populations that are there. So you've got your kind of myoepithelial markers, so P63, calponin, S100, which kind of preferentially stains your myoeps. And then your epithelial component is going to stain with cytokeratins, your CK7, A1, A3, CAM5.2. It's going to really more strongly highlight your epithelial component. And so this is one case where you could do, again, this is kind of a morphology diagnosis, but if you wanted to use IHCs, it could nicely highlight the biphasic cell population. And it's just really kind of pretty in this one. But I think that just kind of stepping back for a minute to talk about IHCs, the pattern of staining is really, really informative, not just whether the stain is positive or negative. So you have to do a little bit more thinking. IHC, I think when you're a resident, sometimes it's just like, oh, is it brown or not, like positive or negative? But unfortunately, nothing in life or pathology is really that simple. And especially in salivary glands, nothing is really that simple. And you really have to kind of figure out what your IHCs are staining, not just, whether it's staining or not. Right, so acute case of epithelial myoepithelial carcinoma. All right, so another case where the low power is very striking. We have a proliferation of cells here sitting next to a big nerve and a vessel, and the tumor is not particularly well circumscribed. We can see little islands of tumor kind of percolating out into the fat, getting close to that vessel. All right, so let's take a step back or rather, let's step in a little bit and see what is making up this tumor. So from kind of a low medium power, this tumor has a bunch of different patterns. So we've got some of these funny looking punched out areas. We've got some areas that look a little more tubular, and maybe here a little tubular as well. And as we go through, we're just noticing a lot of these kind of funny punched out, almost cribriform areas. And that's very characteristic of this tumor. The other thing that we've been kind of seeing is that periodically, what's this? Got a little nerve, and we've got some more nerve running in cross section, and the tumor is just wrapping right around those nerves. So prominent perineural invasion, multiple patterns, including a prominent cribriform pattern. So all of this is describing, of course, adenoid cystic carcinoma. So another very common tumor that we see in the salivary gland. Parotid is the most common site, but you can get these in minor salivary gland sites as well. And perineural invasion is very, very characteristic of this tumor. So I definitely want to see it in these adenoid cystics. It's very, very characteristic. And this is something that is a helpful feature if you're trying to diagnose these in FNA clinics. So if I have a patient come in with a salivary tumor, I always ask about things like tingling, numbness, shooting pains. And if the patient says, "Oh yeah, I've been having these kind of weird tingling sensations or numbness in that area," that's going to really, really, my spider sense is going to go off as a cytopathologist that I might be dealing with a malignant tumor that might be having perineural invasion. So if I do a biopsy and it looks totally benign, I might try to sample a different area and just get a little bit different look, because again, these salivary tumors can vary a lot in appearance, and that perineural invasion for adenoid cystic, very, very characteristic. The other thing that I want to highlight here is you can get multiple different histologic patterns. So you can get tubular. So this one, we have a lot of cribriform patterns. The tubular areas are not super well developed in this one, but let's see. This area is a little bit more tubular, and you can get solid areas, which are said to be more aggressive, as well as being more of a diagnostic challenge, right? So sampling, again, very, very important, because there can be lots of variability within these tumors. All right. So these, again, may be difficult to diagnose on some small biopsy samples. They have a high rate of local recurrence, and the perineural invasion really plays into that, right? So again, if you think about this, this tumor can be very, very locally aggressive because it likes to crawl up the nerves, and it can be difficult to, kind of get all the way around since they're just crawling up the nerves. That can lead to local recurrence, which makes these kind of like a, relentlessly growing neoplasm. All right, and that's it. So that's the end of the talk. Hopefully, we're not going to have any audio and visual syncing up issues with this lecture. And if there's any questions or comments, please put them in the comments field. Hope you enjoyed.